Hello everyone. Is it audible, Dr. Shanthi?
Yeah,
Yeah. Hello everyone. I'm Dr. Pallavi, consultant radiologist at Vijaya Diagnostic Center, Hyderabad. I welcome you all for today's topic of clinico-radiological webinar on ORADs, structural reporting of ovarian adnexal masses. In today's session, we would be discussing about accurate characterization of an ovarian and other adnexal masses, which is essential for optimal patient management. So for today's topic discussion, we have two eminent speakers, doctors. It is my pleasure to invite Dr. Shashikala Kola, who is a consultant gynecologist and obstetrician at Birthright by Rainbow Hospital. Ma'am has done her post-graduation training at Usmania Medical College. She has held many positions, including Joint Secretary and Vice President at OGSH Foxy. She has been past Secretary and Vice President and President at ISO PARB Hyderabad chapter. She is a present Vice President of ISO PARB. Ma'am has interest in endoscopic and vaginal surgeries, include and high-risk obstetric cases as well. She has finished her training in robotic surgeries at Atlanta, USA. Ma'am has contributed chapters for postgraduate textbooks in obstetrics and gynecology. Welcome, ma'am. I would like to welcome Dr. Shanthi, who has finished her MD and MBBS training at Guntur Medical College. She has 15 years of experience in radiology. Before Vijaya, she has worked in CMC Welder for 3 years. Welcome, Dr. Shanthi. I would like Dr. Shashikala to give her clinical insights about today's topic. Over to you, ma'am.
Hello, can you hear me?
yes, ma'am.
Yeah.
Yes,
Good
ma'am.
afternoon. I'm very happy to be a part of this initiative and to learn more about ORADs, because this is one dilemma which all of us clinicians face. The diagnosis of a ovarian malignancy. All of you know that it is the diagnosis and pickup rate is always very late. Patients' complaints are also so vague, so they come to us for some other complaints, sometimes menorrhagia, sometimes weight loss, and sometimes they may go to a physician for GI tract symptoms, things like that. And it is the radiologist who actually raises the red flag for us, because in our case, when we examine clinically, we find an adnexal mass. Then if they come to us, that's when we can suspect there is something in the adnexa, and then the radiologist and their findings give us a lot of insight. And most of us gynecologists, like myself, I do my own ultrasounds, so I do my own transvaginal ultrasound, so I pick up the benign features, look for if there's any doubtful feature. Anyway, definitely we send them to the radiologist, but my antenna also are up when I do my own scan. So I would like to learn a lot more about this new system, because we've been over the years learning about the IOTA, International Ovarian Tumor Analysis Group, and then the Adnex model, and the lexicon model. So now I would like to learn from Dr. Shanthi about the ORADs. Over to you, Dr. Shanthi.
Thank you, ma'am. Very good afternoon, ma'am. Good afternoon to everyone. So today's my webinar topic is ORAD, which is a structural reporting of ovarian and adnexal masses. So actually this ORAD stands for Ovarian Adnexal Reporting and Data System. So basically it is an ultrasound risk stratification and management system. So we provide, using this ORAD system, we can do consistent interpretations, and also we can decrease the ambiguity between reports. And also this increases our accuracy in assessing the risk of malignancy. And also we can do some management recommendations for each risk category. So basically, this ORAD system is developed by American College of Radiology. So they have taken the pattern-based approach of the North America and the European approach, which ma'am said, like the International Ovarian Tumor Analysis System, and they have did a collaboration between and developed this ORAD system. So this ORAD system actually recommends six categories for ovarian lesions. That is ORAD 0 to 5. So from 0 is like the normal things, and to the going to the 5 it will be the high risk of malignancy. So this is the basically the ORAD system. In ORADs 0, which is an incomplete evaluation, and ORADs 1 is the physiological category, where we see the normal physiological things in the normal premenopausal ovary. And ORADs 2 is always a benign category, very less risk of malignancy, less than 1%. Whereas where ORADs 3 is the low risk of malignancy, 1 to 10%. Whereas 4 is the intermediate risk, 10 to 50%, and 5 is with the high risk of malignancy, which is more than 50%. So there are some governing concepts when we are using the ORAD system. So whatever ORAD system we do and do the recommendations, it is depending upon the finally by the professional judgment of the clinician. And the second thing is, if this ORAD system applies to average risk patient with no acute symptoms. And also no substantial risk factors for ovarian cancer. But if there is a significant history of family history, gene mutation, then the management will differ from what the ORADs recommends. And the third thing is we require a ultrasound specialist when you do a ORADs categorization, and we should always categorize the patient as pre and post menopausal. And so the management part will differ in the pre and post menopausal categories. And also when you talk about the size of the lesion, we have to take the largest diameter of the lesion, regardless of the plane, whatever is the plane, but we require the largest diameter of the lesion that we should measure. Another thing is, we are basically applying these ORADs to lesions of the ovaries and the fallopian tubes. Sometimes, if you are in doubt whether this is from ovary or tube, still, if you think it can be still from ovary and tube, you can apply the ORADs. But if you think this lesion is definitely separate from the ovary and the tube, then you can't apply the ORADs unless it is like a para-ovarian cyst or a peritoneal inclusion cyst. So in case of para-ovarian and peritoneal inclusion cyst as well, we apply the ORADs. And the next thing is the transvaginal ultrasonography is a must. So we do the recommendations depending upon that. And if you see multiple lesions, bilateral lesions, then you should categorize the each lesion separately and give the highest one with the ORAD score for management. So this is the ORADs classification, actual ORADs classification. So in this, we can see that this is ORADs 0. ORADs 0 is like incomplete evaluation. So why there is incomplete evaluation is, sometimes you can have a lot of bubble gas, where you are not able to exactly characterize the lesion. Sometimes the lesion can be very large, and the when you are doing a TVS, there can be higher adnexia, so that you are not able to categorize the lesion. And also when you are not able to do the TBS, that is sometimes patient is not cooperative, or you are seeing an unmarried girls. So in such cases, your ORAT's evaluation is incomplete, so you keep it as 0. So in that case, the management would be like, you have to do the repeat study, or you have to go for alternate study like MRI and all. Next category is ORADS 1. This ORADS 1 is the normal physiological category. This applies to premenopausal women. So in this case, there are two lesions are included. One is the follicle, which is simple cyst-like thing less than 3 centimeters, and we include the corpus luteum, which is also like less than 3 centimeters. So this is a physiological category, and we'll just have some look at the images. This is the simple follicle which we are seeing, which is like a simple cyst and less than 3 centimeters in size. And then we can see the corpus luteum, which can be seen as with crenated margins, some internal echoes, and also the peripheral color flow we can see. Sometimes we don't see the cystic component, we just see the hypoechoic component also, and again with the peripheral flow. And also you can see these are the similar corpus luteal images, where you can see the cystic or the hypoechoic component, peripheral flow, then the crenated margins. This is a peripheral flow, sometimes showing double corpus luteum also. So these are all the images of the corpus luteum. So these all things come under the ORADS 1 category, which is the physiological category. So here the management thing is it's a physiological, so we need not do anything and doesn't apply in a postmenopausal woman. Next, coming to the ORADS 2 category. This is like benign category essentially, and here we include three types of lesions actually. We include a simple cyst, we include an unilocular cyst, and some classical benign lesions like the hemorrhagic cyst, endometriotic cyst, then the paraovarian cyst, peritoneal inclusion cyst, hydrosalpinx, and all that. So basically, if you come to the simple cyst, we include a simple cyst which are less than 10 centimeters. Simple cyst is like smooth inner wall and no echoes and no septations also. That is a smooth cyst. So we include such cyst which are less than 10 centimeters. And coming to the unilocular cyst, this unilocular cyst we include what we mean by unilocular cyst is they have a single compartment and they can still have some incomplete septations. The septa are not complete, there are incomplete septations, and there can be some echoes as well. So those are the unilocular cyst, and here also we include the unilocular cyst which are less than 10 centimeters, and also we include some classical benign lesions which are also like less than 10 centimeters. So coming to these lesions, so we are including the simple cyst which are less than 10 centimeters. We are including the unilocular cyst less than 10 centimeters, and also the classic benign lesions. So these are the lesions. So this is a simple cyst which is less than 10 centimeters, and these are the unilocular cyst where we have an echoes, or sometimes we can have an incomplete septations, more than one or more incomplete septations. So these all we include in the ORADS 2 and the classical benign lesions. So just looking at the classical benign lesions, what we are including here is the hemorrhagic cyst. All these classical benign lesions should be less than 10 centimeters when you are putting them in the ORADS 2 category. So we know that the classical hemorrhagic cyst is like a reticular pattern. It will have a reticular pattern representing the fibrin strands. Sometimes it can look like a retracting clot where you have an echogenic component with angular margins, straight margins like that. And we know the dermoid features. Dermoid features can have an hyperechoic components, the floating echogenic structures like that, and also the endometrioma will have ground glass or homogeneous low level echoes. These are all the lesions, and also the simple para-ovarian cyst. We know that we see the cyst nearer to the ovary but separate from the ovary. And typical peritoneal inclusion cyst, it will just follow the contour of the adjacent pelvic organs, and sometimes ovary is either at the margin or suspended within the lesions. And also the hydrosalpinx, we know that it is a cystic tubular structures with incomplete septations. So these are the classic benign lesions what we are seeing. So here the classic benign lesions, this is a hemorrhagic cyst. You can see the reticular pattern. This is a retracting clot like hemorrhagic cyst. Then we are seeing the typical dermoid cyst with hyperechoic component, echoes, then the hyperechoic floating areas, the spherical structures, everything. Then the endometrioma is like the ground glass low level echoes, uniform echoes. That is the endometrioma. Then this is the paraovarian cyst where you can see a simple cyst beside the ovary, and then peritoneal inclusion cyst, and then the tubular cystic hydrosalpinx. So these are all the images of the classical benign lesions. So that is the ORADS 2 category. Now coming to the ORADS 3 category. In ORADS 3 category, we are including the lesions with a low risk of malignancy, that is less than 10%. So here we include unilocular cyst, we include the multilocular cyst, and we include the typical benign lesions and also the solid lesions. We are including four types of lesions here. But the thing is, the unilocular cyst should be more than 10 centimeters. So less than 10 centimeter is goes into ORADS 2. So it is more than 10 centimeters. Sometimes it can be of any size, but if it has a irregular wall, if you are seeing an irregular wall with less than 3 height, then any set size doesn't matter. It goes into ORADS 3 category. And then the typical benign lesions which are more than 10 centimeters size. And then we include the multilocular cyst. These multilocular cysts should be less than 10 centimeter size. They have a smooth inner wall, and the color flow should be 1 to 3. Here we start taking the color scoring in the ORADS 3 category. We will just see what the color scoring is. And the last lesions we include here is solid smooth lesions. They can be any size, but the color scoring is again 1. It is just 1. So we'll just have a look at these lesions. ORADS 3 lesions. So here we are including the simple cyst, the unilocular cyst, simple which are less than 10 centimeters, unilocular cyst with any size with wall irregularity, then the multilocular cyst which are less than 10 centimeters and they don't have any solid component, and color score is 1 to 3. And we are including the avascular solid lesions. Any size doesn't matter, but they should have a smooth margins, and the color score is 1. So now we are including the color scoring system. What is the color scoring system is, when you see no flow at all in the lesion, it is a color score 1. If you are seeing like mild flow, minimal flow, it is like 2, and then moderate flow, it is 3, and it is color score is 4. Then it is a very strong flow. So these are the some of the ORADS 3 category lesions. Here we are seeing the unilocular cyst, which is more than 10 centimeters. It can be simple or non-simple unilocular cyst. And then we'll see the typical benign lesions, which are again more than 10 centimeters. Ovarian cyst, unilocular cyst, any size, but irregular wall. We can see the irregular wall here. This irregular wall has less than 3 mm height. Height is from the base. So it has less than 3 mm height. Such lesions you should include in 3. And then the multilocular cyst, which is smooth margins, that the color score is 1 to 3, but the size is less than 10 centimeters. And then we are including the solid lesions, smooth solid lesions, which are showing no flow, avascular, almost avascular lesions. So these are all included in ORADS 3. Coming to the ORADS 4 category, in ORADS 4 category, we are again including the unilocular, multilocular, and the solid lesions. So here the unilocular cyst will have a solid component. So once the solid component starts with the cystic things, it comes to ORADS 4 category. So this unilocular cyst can have solid component, any size, color doesn't matter, color score also doesn't matter, and the papillary projections should be less than 0 to 3, that is less than 4. And we include the multilocular cyst with no solid component when the multilocular cyst size is more than 10 centimeters. Still, it has a smooth inner wall and color score is 1 to 3, but the size has increased. And then, if the color score becomes 4, or if it is having irregular wall, then the size doesn't matter. Any multilocular cyst comes into 4. And also, multilocular with solid component also comes here, provided the color score is 1 to 2. And then solid lesions, we have included color score 1 lesions, that is avascular lesions in 3. Here the color score becomes 2 to 3, that is a moderate, mild and moderate. So those come under ORADS 4 category. So ORADS 4 category, once again, 10 to 50% risk of malignancy. We have included the unilocular cyst with solid component less than 3 papillary projections. And the papillary projections, what we mean is, it's like a solid component with height which is greater than 3 mm. Irregular wall, we said less than 3 mm. These papillary projections should be more than 3 mm, and they protrude they arise from the septation or from the wall, and they protrude into the cyst cavity. And multilocular cyst, we are including more than 10 centimeters or any size if they have a irregular wall, or if color score is 4, then or with a solid component with the color score of 1 to 2. And we are including the smooth solid lesions. When we mean a solid lesion, it should be 80% solid component, and with a color score of 2 to 3. So these are the lesions we are including. So we can see the ORADS 4 lesions here. These oral four lesions here, you are seeing the multilocular cyst, which has a smooth contour and color score of 1 to 3, and the size is less than 10 centimeters. But if we you can see in the next that the color score has become 4, that is a very high vascular thing, then the size doesn't matter. And we can see that these are irregular walls, and then also size doesn't matter, any multilocular cyst goes into 4. And then we are seeing the unilocular cyst with solid components, and we are seeing 1 to 2 papillary projections. These are also going into 4 category, and also the multilocular cyst with solid component, but the only thing is the color score is less, 1 to 2. And we are including the smooth solid lesions here with a color score of 2 to 3, moderate flow. So coming to the last category, what we are seeing in the ORADs is the ORADs 5. So this is a high risk category, more than 50%. Here we are including the unilocular cyst with papillary projections of more, 4 or more. Here the color score doesn't matter anything, and multilocular cyst with solid component. Now the color score has come to 3 to 4. And then we are including the solid smooth lesions, if the color score is 4, and also the any size irregular with irregular margins, and sometimes association with the ascites and the peritoneal nodules. These also come under Vorad's 5. So the ORAD's 5 lesions are the high risk lesions, and we are including the unilocular cyst with papillary projections more than 4, multilocular cyst with solid component high color score, then smooth solid lesions with high color score, and irregular solid lesions, and association with ascites and peritoneal nodules. Here, one thing I would like to suggest is that when you are seeing the lesion and it looks like a physiological cyst or very benign lesion, then if you are seeing an association with ascites, better rule out the other causes of ascites rather than keeping it in the ORADS 5 category. So this is the description for the fluids, what we see generally on ultrasound. When it is confined to pouch of Douglas, you can say just the cul-de-sac fluid. But if it is beyond the uterine fundus and also anterosuperior to the uterus, then we could start calling it as ascites. And nodularity or diffuse thickening of the peritoneum also, we should be carefully seeing to include the lesion in the ORADS 5 category. So these are the some of the ORAD's 5 lesions. You can see here the unilocular cyst with the 4 or more papillary projections, and then we are seeing the multilocular cyst with solid component, and the color score is high, 3 to 4. And we are seeing the smooth solid lesion with color score of 4. Here we are seeing the irregular lesions. These are the irregular lesions. Size and color score doesn't matter once the contour is irregular. And then we are seeing the ascites and the peritoneal thickening nodules. All such things come under the ORADS 5 category. So management part, actually the ORAD's recommendations is that initially the benign looking lesions, usually you can suggest a follow up, or if you think they are increasing in size or they are persisting, then the further evaluation with MRI and the gynecologist intervention is required. But if you come to the high risk categories like 3, 4, 5, always ultrasound, second ultrasound or follow up ultrasound or MRI and all this, MRI recommendation, and also the intervention by the gynecologist or gynecologist is required. So to conclude, these ORAD's category lesions. So whenever we look at in our daily practice, when we look at these lesions, so these ovarian and adnexal lesions can be, what we see is either cystic or a solid thing, or the classical benign lesions. So cystic can be unilocular, multilocular, and the classic benign and the solid thing. So once you see the lesions, how you should approach the lesion to put it under the ORAD's category. So first of all, let us see if you are seeing a simple cyst, where it is a just a cystic component which is a smooth wall, no echoes, no septations, nothing. And if you are seeing a premenopausal lady, think of a follicle. Then if it is like postmenopausal, then it goes into ORAD's 1 category, which is physiological. But if you see it is in a postmenopausal woman, you can put it under ORADS 2 category, but no, nothing, no intervention is required. But if you are seeing lesions like around 10, less than 10 centimeters, 3 to 10 centimeters, they all come under ORADS 2 category. So usually the follow-up ultrasound, like 8 to 12 weeks in premenopausal or 1 year follow-up is required in postmenopausal women. And then regarding the unilocular cyst, so unilocular cyst, if you are seeing less than 3 centimeters, in premenopausal, it comes under ORADS 2, where we don't require any intervention. Whereas in postmenopausal women, ORADS 2, but we need to do the follow-up ultrasound or MRI. And less than 10 centimeter lesions, they also come under ORADS 2, but follow-up is always required in pre or postmenopausal women. Whereas if you are seeing lesion more than 10 centimeters, it goes into ORADS 3 category, where always a follow-up or further evaluation and gynecologist help is always required. And if you are seeing unilocular cyst, which is irregular wall is less than 3 mm, that's with the irregular wall, that also comes under ORADS 3 category. And if you are seeing with solid component and less than 3 papillary projections, ORADS 4 category, and more than 4 papillary projections, ORADS 5 category, and all these will be requiring further evaluation and intervention. Classical benign lesions like the what we said, the hemorrhagic cyst and all, endometriotic cyst, dermoid cyst, which are less than 10 centimeters, they are going to ORADS 2. More than 10 centimeters, ORADS 3. And except for the paraovarian cyst, others can be followed up, and if there is persistence or increase in the size of the lesion, follow up ultrasound, MRI, and all that is required. Coming to the multilocular cyst, so whenever you are seeing a multilocular cyst, if it has no solid component, less than 10 centimeters, smooth wall, less color flow, it comes into ORADS 3 category. And if you are seeing what are all the conditions where it goes to ORADS 4 is still no solid component, but if the size is more than 10 centimeters, higher color score, irregular wall, irregular separations, everything goes into 4. And also solid component with the less color score, 1 to 2, that also goes into ORADS 4. But if you are seeing a solid component, multilocular cyst with solid component 1 to 2, then it goes into ORADS. But if you are seeing with high color flow, like 3 to 4, then it goes to ORADS 5 category. Lastly, these solid lesions, once you see the solid lesions, if you are seeing very smooth margins, less color flow, avascular almost, then you put it under ORADS 3. But if you are seeing 2 to 3 color flow, you put it under ORADS 4. But it's high color flow, it's like ORADS 5. But if you are not seeing the smooth margins, irregular margins, size doesn't matter, color doesn't matter, you just directly put it in ORADS 5. And association with peritoneal nodules, ascites, these also depending upon the lesions. So we have to look whether you are looking at a physiological cyst or a benign lesion. Then otherwise, with high suspicion of malignancy lesions, these with the presence of ascites and peritoneal nodules, you can put the lesion under the ORADS 4 category. Thank you so much.
Thank you, Dr. Shanthi, for your comprehensive and informative presentation. You have covered all the relevant areas related to ORAD's ultrasound stratification and management system. I'm looking for any questions in the audience.
If I may say, Dr. Shanthi, it was a very clear presentation. You have mentioned all the various scenarios, at least the radiological picture. And then for a gynecologist like us, we have to add our clinical findings, and then follow up also. Actually, we also say, sometimes it's not that 3 months interval. We always say whenever you become symptomatic, though we say come after 3 months, sometimes within a month they can become symptomatic. So whenever they become symptomatic, also we ask them to come when they are in the CORADS 2 or 3, especially postmenopausal women with a CORADS 2. We always tell them. And just I wanted, out of my interest, can I ask a question? This. So earlier were you using the Adnex model, or directly from IOTA you have moved to the ORADs? So are you trying to correlate, because the Adnex model I think has more The sensitivity is okay, specificity is little better than the lexicon model. So, and then sometimes they over diagnose compared to
Yes.
the ORADs. So, anything you want to comment on that? What would you like the radiologist to follow? Which method finally? Is it ORADs or Adnex model or the IOTA? What are the advantages of following the ORADs?
So ORADS is actually it's like a collaboration, ma'am. So I think the ORADS model will be giving us better stratification, risk stratification.
The
And
uniformity in
also,
the report because of
yeah,
the
if
standard
everyone follows the
lexical
same classification, I think it
scores.
will be easier, yeah, for us to
Yes.
follow up also on our patients. Maybe, yes. So we need to educate our gynecologists now on the ORADs, and also that they follow that in choosing which cases they have to operate. And I have seen all these stages in my cases. So if I suspect there is a malignancy or sometimes a borderline, again it can be a borderline tumor. So I always keep the oncosurgeon uh, at hand. So I put in the scope and tell the oncosurgeon to be available. And then if it is where we need to do the complete procedure, where it can be done, we can debulk it, put it in a this thing and remove. Recently, I had one patient who they have given it as a, she had a previous fibroid myomectomy was done. Then she had another solid mass. So they have diagnosed ultrasonologically a broad ligament fibroid. But I asked her to go for an MRI. She did not go for the MRI and she had come. And we opened, it was actually a solid ovarian tumor. It was actually a malignancy. So I think these are the cases we would not like to, you know. Otherwise, I would have put in a scope and taken a biopsy and come out, because the diagnosis of a fibroid, previous history of a fibroid, myomectomy done, so, and a younger patient. So I think these are sometimes traps for us. So when do you recommend MRI for these patients?
When it is in ORAD's zero category, ma'am, when the lesion is large and there are other, when there are peritoneal nodules as well as ascites, to look for the extent of the disease, as well as, and if there is a solid nodule which cannot be categorized according to, like, we feel that there is more study needed.
Actually, we do get sometimes patients with 36 centimeters, 40 centimeters, young 19-year-old. I had a patient with a 35 centimeter endometriotic cyst. So came after, soon after marriage, we did a laparoscopic procedure. But these are cases rarely we see, but they do come. A benign lesion which is much larger. Uh, but as you said, all the ultrasound features are all of the benign type. The margins are not smooth. The internal margins are smooth, but the size is very large. So these patients, according to your these ORADs, they fall into the category
Three,
ORADs
ma'am.
4, 3 or
ORADS.
4.
Classical benign with more than 10 centimeters, 3.
I cannot see any questions from audience as well. So I would like to take the opportunity to thank Dr. Shashikala ma'am for the concerning to be with us for today's session and giving her important insights as well as opinion. I also would like to thank Dr. Shanthi for the wonderful presentation. I hope the audiences also have gained a lot of knowledge from this session. Thank you, ma'am. Thank you, Dr. Shanthi.
Thank you.
Thank you.
I,
Thank you, Dr. Shanti. Thank you, Pallavi.
yeah, thank you.